Melanoma Matters is an educational resource. The content represents our opinions and does not constitute medical advice. If you're a patient with questions specific to your situation, please consult your medical practitioner. Everybody say would. Would.
Top of the podcast is appropriate. We're leaving all that in. Just kidding.
Yeah.
Just joking.
More wood jokes. All right, so should we start now?
Let's do it.
Okay, ready? Right. So, hi everybody. Welcome to Melanoma Matters. I'm James Larkin.
And I'm Sapna Patel.
And I would like to welcome a special guest today, our third guest, Dr. Andreas Schmitt.
Hi. Thanks for having me.
Okay, so listen, we're going to need to fasten our seatbelts here, which actually, on a digression, I heard Lex Egermont say once when he was just about to present some data from an adjuvant interferon trial. Anyway, in today's episode, we're going to go to the next level, okay? So already we've talked about the importance of looking at figure 1. And now we're going to talk about the importance of looking at the supplementaries with Andreas, our special guest. So Andreas, couple of questions for you just to warm up maybe. First of all, tell us where you work and your background, how we know each other. And then maybe as well, why you're an oncologist. That'd be good to hear.
Why I'm an oncologist? Yes. So I'm a medical oncologist at the University Hospital in Basel, but in Switzerland. I'm from Germany and went to med school in Mainz, which is close to Frankfurt. And there I also started my training in internal medicine, which I finished in Basel. And then I started medical oncology at the University Hospital in Basel. And I went to London to the Royal Marsden for 2 years to work in your group. And I left in August 22. Yes, already 2 years. And now as an oncologist in Basel, I'm still treating patients with skin cancers, mainly melanoma, but also GU cancer. Why did I become a medical oncologist? I like taking care of my patients for a long time, not only like seeing them for 2 or 3 days. It's good to get to know them. And also it's good to be where it's important to make good decisions, right? Kind of at the front work. Yes. Maybe that's a brief summary.
Did you learn any of that good decision making in your 2 years at the Marsden under James? What exactly did he teach you?
How to make very quick decisions.
Oh.
Be efficient. Yes.
He's fast, is he?
No, like be pragmatic, prioritize, keep your focus on treating the cancer where you're best. Yeah.
Did he teach you how to deadlift, or did you already know how to do that?
I already knew that.
Okay. So you couldn't teach
I
him.
think maybe that's why I was accepted, probably. I'm not sure.
That was the qualification.
That was a bar, yes.
Andreas is a keen climber, actually. So, I mean, we probably shouldn't ask him to take his shirt off or anything, but, you know, climbers, very strong upper body, right, Andreas?
Sounds like he wants you to...
Yes, I mean, I won't disagree, right? Yes.
Can you turn your back to camera and show us your traps and lats? Just kidding.
So listen, I'm still not clear about this, but why would someone who's German want to work in Switzerland? You know, as a general question for people who maybe don't know the system and stuff.
Yeah, so actually it was not like I was younger. I didn't have a plan for the next 20 years. And it's just with my girlfriend back then, we wanted to change city and there were some options and Basel was one of them. And I guess most Swiss people will disagree, but if you live in south of Germany or you live in Basel, it's not a big difference. So that was easy change for me. But then in Germany, as an oncologist, you usually don't treat solid cancers. Usually you have hematology and solid cancers will be treated by a specialist like GI, by the gastroenterologist, lung cancer. Yes, it's very different. And so I liked that about Switzerland.
Yeah, and maybe just one final point on the systems as well for people who aren't necessarily familiar with it. I think I'm right in saying that in the Swiss oncology system, there's probably less subspecialization than Sapna you or I might be used to. So, Andreas, you've already said this to some extent, but quite often faculty level oncologists will be treating quite a lot of different tumor types, and maybe even multiple different tumor types in one clinic, right?
Yes. So I think the healthcare system in Switzerland is great. It's very good, but numbers are small. So if I would only focus on skin cancers, I would usually work on Monday, and that's it. So no, I have to treat more patients.
Anyway, so yeah, getting back to the subject, which is reading the supplementary. I guess Sapna, you and I have talked about this a lot.
But I was going to tell you guys how this even came to light, because it was somewhat, maybe not that well in the public sphere, what you guys uncovered. So I was at a meeting a couple of years ago, 18 months ago now or so. James, this was our Munich debate. And so we were doing our debate. You left the conference maybe a day early before it ended. No judgment. Although Miracle said you come and you give your talk and you stay for everybody else's. No, I'm only kidding. No judgment. But then you had mentioned something. You weren't sure if you were going to get a prickly reception from some people, and I didn't really understand. And you said, because of what we wrote about TRICOTEL. And I said, well, what did you write? And you said, oh, well, we realized, there might have been some issues. So we're at dinner and I said, what's going on with TRICOTEL? Is there some controversy? And I think, James, you had mentioned you reached out to these investigators and said, look, we are giving you guys just a chance to help us understand. I think they maybe realized, oh no, we do need to probably take another look. So they went to the sponsors' data and looked. And it was not even a month later that the republication. So this is all to say, I think many people did not realize that this publication had been retracted on the investigative work of Gumshoe, Schmitt, and Larkin. And so then it was retracted, but then, fortunately they were able to go back and look and then republish it in Lancet Oncology. When this data was presented, it was potentially ASCO 21 or 22. Does 22 feel right to you, maybe?
Yeah. Was published in 22.
Yeah, so maybe it was around there. I remember walking on the Sky Bridge, watching it on my device because I was going back to catch my flight home Sunday. And on the basis of that, we had a conversation in SWOG. We have a study called S2000, which is for metastatic melanoma with brain mets as the first appearance. And based on TRICOTEL, it looked like, look at this triple combination that could be effective for the symptomatic cohort. This first appearance of brain met study was having trouble enrolling because it's hard to find that patient population, it turns out. And so we actually went back to SWOG pretty quickly after that ASCO presentation before the publication and redesigned that study to drop the asymptomatic cohort and only enroll symptomatic, because here now it was looking like, oh, we are on to something for symptomatic brain mets. Mm-hmm. So the implications are we redesigned a study for SWOG study. So this is all to say kudos to you for what you guys uncovered, but maybe you can tell us where this was historically for you. How did it come about? How did you figure things out? Who taught you to look at the supplementals?
Well, listen, Andreas is going to tell the story. I'm not going to, but it's kind of you to say it was us, but it was Andreas. It wasn't me, actually. It was Andreas who came to me with this. I remember we were in clinic, right, Andreas? But go on. Over to you.
Yeah. So maybe it makes sense just to say something about TRICOTEL so people maybe understand the trial. But I will keep it brief. So TRICOTEL was a single-arm trial investigating triple therapy with atezolizumab, cobimetinib, and vemurafenib So everything from Basel, Roche, right, for treating patients with metastatic melanoma with brain metastasis. And they also had a cohort of BRAF wild-type patients, but that was closed early and not focus of the paper. And then they had the big cohort of patients with BRAF V600 mutation. And interestingly, they also allowed patients to have symptomatic brain disease and have corticosteroids, I think up to 8 milligrams dexamethasone. So really like patients, ill patients, difficult to recruit for your trial. And then the paper was published in Lancet Oncology, and the primary endpoint was objective response rate. Secondary points were like duration of response, PFS, OS, what we usually have, right? And for the whole cohort of patients with BRAF mutation, response rate was, I think, 50%, like investigator assessed, and duration of response was 7 months. So it was okay, but not like very, very good, but what you would expect, right? But they also described a cohort of patients with symptomatic disease, 24 patients, so they had symptomatic brain metastasis or corticosteroids or both, 24 patients. And here the response rate was more than 55%, and the duration of response was 10 months. So pretty good if you compare it to other competing trials, right?
Yeah.
And that they also discussed that. They said, look, this is maybe the best data up to now we have for patients with symptomatic brain metastasis, and maybe triple therapy is the way to go. And they also explained why. So first patients had an introduction phase, 1 cycle with BRAF MEK inhibition, and in the second cycle they added atezolizumab. Yes, and then in the second step, I looked in the supplements and there were some issues. Yeah.
Yeah, I mean, that's an excellent summary of the trial. So then you probably had the instinct, correct me if I'm wrong, you said, okay, well, how do I identify a symptomatic patient in clinic? What is the characteristics of symptomatic? And you went and read the supplemental.
Yeah, but maybe Andreas, I don't know, I don't remember well because it was a while ago now. I suspect you and I would have been sitting together in clinic and chatting. And, you would have said, oh, look at this. And I would have probably said, that's kind of surprisingly good based on what we know already from all the other data and also from clinical experience. It's very, very difficult patients to treat. And, without getting into too much the differences between Bemcobi and, say, Dabtram or Encobini, or the differences between atezolizumab and, say, Pembro, Nivo with Benivo. My feeling certainly with atezolizumab, it just isn't a drug that has such a strong track record in melanoma as either Nivo or Pembro. I think so. It surprised me, I have to say. So then we were talking, and then I suspect that's where the supplementary comes in, right, Andreas? So you went and looked.
Yes. I think that's what happened, right? And one thing, I was also surprised that usually you need IPI to treat patients with brain metastasis. And that was missing. And one point was, why would this combination be better in symptomatic patients than in asymptomatic patients? It didn't really make sense.
Yeah.
And you could argue it's a small trial, 66, 64 patients, chance might play a role. Yes.
Do you know what type of error that is? Type 1 or type 2? Because we stumble on that all the time. It's type 2. It's a type 2 error, small sample size.
Sapna's got a special method of remembering that whether something's type 1 or type 2, but I'm not sure it's fit for public consumption. Is that going to remember?
For a bar night one night. Yeah.
Okay.
All right.
Okay.
Sorry, Andreas.
Looking forward to it. Yes. And yes, and like you said, so those are very difficult to treat patients, And so you want to understand if the patients in the trial are the same patients you see in clinic, right?
Okay.
And in the supplement, they had a table with all 24 patients who had symptomatic disease or corticosteroids. And for every patient, they listed steroids, yes or no, prior radiotherapy, yes or no. And they also listed the brain-related symptoms. And for 6 of those patients, brain-related symptoms were either elevated LDH, tumor pain, which was like abdominal pain, stomach pain, so clearly not brain-related symptoms, right? So I read the table and I thought they can't be part of the cohort, but maybe I'm missing something. So I read it a few times, but I couldn't figure it out. And of those 6 patients, 5 had a partial or complete response. So they were contributing to the good response rate, right? And I think that's when I came to you and said, "Look, did you read the supplement? What do you think?"
And I would have probably said, "Are you sure, Andreas?"
Yeah.
And so then I guess we read it together and we talked about it a bit more. And, it completely made sense what Andreas had said. And I think then I sent a message to Hussein and Reinhardt saying, "Look, we don't really understand this." And then they said that, they would go back and look at it. And I think, we all know each other. It's a small world. And I said, look, we probably, I think, need to let the journal know about this as well. So I think we sent a message to the journal. And of course, I let Reinhardt and Hussein know about that. And then they reanalyzed it. And I guess we've sort of covered the rest of the story, really. So, yeah.
Is there anything to say about your letter to point out and their response and then the republication, the new data?
I'm not sure, really. I think it was all very factual. It was all, very amicable as well. And maybe the other point that we haven't sort of really brought out, I think this is part of what we do in academia, actually, is that we look at data and we talk to colleagues about it. If we don't understand it, we discuss it. And we try and make sense. And, and if it isn't making sense, we go back to the source and just double check the source. And that's what we all did. So, and I think the editors, I haven't reread it, honestly, actually, Andreas, that I think the editors of the Lancet Oncology made that point in a small editorial, a kind of accompanying article that that this is important. So for me, that's other than reading the supplementary, that's the biggest message here. I think that sometimes things do go wrong. Not for any malicious reason.
This is not a criticism of certainly not the authors or this is just natural. If anything, it's a wonderful story about how an intrepid fellow can read something and ask just a good question. Does this make sense? And I'm sure James threatened you with some pull-ups or something. If you're wrong about this, you're going to do X number of pull-ups. I'm sure there was some gym, wager in there. But how somebody can read something and say, I just want to make sense of this. Does this make sense to you? Verify. But it also speaks to the level of peer review. We're all so busy here that the company, maybe somebody at the company should have said, does this make sense to us internally? Does this data make sense to us? Then the authors, and of course they tried to make sense of it in that original discussion. Maybe it's this run-in period of BRAF MAC. We also note that it's unusual to have a high response rate higher than the general cohort, but maybe this, that, or the other. So they were rationalizing it, but maybe first just verify the data. And then a reviewer. There had to have been 2 or 3 or 4 reviewers for this article where it didn't seem to trouble them. Again, supplemental. So it's like, you've made it through the paper. Do you take the extra time to go open that extra file on a journal website? It's often a separate link. And, but then ultimately it goes back to what we do in clinic. We recorded an episode the other day, it might have been Keynote 06, James, where I was like, okay, there was so much potential because I still don't know how to help these patients in clinic. If they're a CR, PR, and recurred, I'm like trying to parse together. So it comes back to, does your clinic population mirror what this study showed? And as soon as you said, well, I don't think I would have called abdominal pain or an elevated LDH symptomatic, that to me, anyway, I think that's just such a great story of how these things make it through lots of levels of review, but then ultimately the reader, what happens at the readership matters. So well done.
Yeah. I'm going to ask you now then, Andreas. Right. So one thing just to ask about and to be clear about is the republication of the TRICOTEL study. So Andreas, maybe you could say a few words about that.
Yeah. So I think the authors went through all patients again and reclassified patients as having symptoms, yes or no, having corticosteroids, yes or no. And actually, the cohort of patients increased. So it went from 24 to 26. But the objective response rate was worse. I think it was like in 30-something% or so. And
it's not that they added 2 patients to that cohort, it's that they actually removed those 5 or 6 that you had noted. It's not that,
yes,
and then they found others that were coded as asymptomatic that they folded in.
that were symptomatic. Yes, exactly. Yeah. And duration of response was, I think, back to 7 months from 10. So something what you may expect. Yes.
Mm-hmm.
And they changed the conclusion from promising activity to being active. Yes.
Yeah.
Yeah, I mean, I loved how you said intrepid fellow as well, because that sort of almost sounds so like something from sort of 19th century, Jules Verne, an intrepid fellow. But I'm assuming that you meant fellow with a large F. Although Andreas is both, really. He's an intrepid fellow and he's an intrepid... Well, he's not a fellow anymore. He was an intrepid fellow. In
Right?
both senses of the word fellow.
We like a double entendres here on Melanoma Matters, okay? So it matters.
All good.
So, but you didn't stop there. I mean, you have continued this sort of reading carefully. What else have you guys worked on or uncovered? Or I think we got something coming out, a little side editorial coming out soon that we all sort of found to be an interesting topic.
Yes. Who wants to start?
I think you should, Andreas, because again, I think Sapna, you and I talked about that a little bit, hadn't we? And then Andreas, you sent me an email. So yeah, let's talk about that.
Yeah. So again, I will keep it short.
We obviously ramble, so no need.
Yes. Yes.
Listen, we're having fun.
Yeah.
Yeah. I guess every entity has its own topics. Everyone loves to argue about, and for melanoma, for sure, it's do we need ipi-nivo or is nivo enough? It's one of the topics, right?
Or Pembro for the record.
Or Pembro. I'm sorry. Yes.
Single-agent anti-PD-1.
Yes. Yes. And there are good reasons for both opinions, and it can be difficult to choose. And for that reason, everyone would love to have a good biomarker, right? And since the very beginning, people hoped that maybe PD-L1 could be a good choice for obvious reasons, right? And in I think 2 or 3 months ago in JAMA Oncology, there was a letter by Mark Donyer and Vinay Prasad, and they made a case that PD-L1 expression might be a good choice as a biomarker to decide which patients need dual checkpoint inhibition, ipi-nivo, and for which patients PD-L1 monotherapy, like nivolumab or pembrolizumab, might be enough. And they said, it seems like for patients who have a PD-L1 expression greater 1, monotherapy seems to be sufficient. And they built their case on three trials. The first one is the famous checkpoint 067, right? And I think it was already in the first...
He's having palpitations because you said checkpoint.
Yeah. Oh.
He's like, do I correct him or not?
You should have. Checkmate
Red and
067.
yeah.
Yes.
Go on.
Yes. In Checkmate 067, there was this subgroup analysis, like the effect of ipi-nivo versus nivo alone, depending on PD-L1 expression. And it seemed like for patients who have PD-L1 expression greater 1, monotherapy seems to be enough because the results were more or less the same. Yes. And then there was the next trial, Relativity 047. Again, nivo-relatlimab versus nivolumab. And again, there were subgroup analyses. This time, I think, pre-specified. And there was like a similar result. It seemed like for patients who have PD-L1 expression greater 1, you don't need dual checkpoint inhibition. And then in European Journal of Cancer, by a group from Denmark, I think also around Mark Donia, they published a retrospective analysis of patients treated in Denmark with either nivo and ipi or just nivo or pembro alone. And again, they stratified by PD-L1 expression. And again, they had the same result. It seemed like if you have a PD-L1 expression greater 1, you don't need dual checkpoint inhibition.
Is there a caveat here that all of these analyses were done without statistical power? These were observations, really exploratory. Yeah.
Yes, and I think that's what we described in our comment. Yes. So this is just the story why a lot of people think for good reasons, maybe, or it's worth thinking about it, that PD-L1 might be a good biomarker to help with this difficult decision, right?
And then so we had a side conversation because I had brought this up at, some times, and then maybe in an early episode I'd mentioned, it might be a tool I use in the exam room. And then we saw the paper. I think somebody had sent it to me. We kind of chatted about it. And then he said, look, Andreas has emailed about that paper, and he feels very strongly that maybe there's a counter position to PD-L1 as a good biomarker. And so then what happened?
Yes, I read the paper, and I remember that in clinics we discussed a lot of things, but we actually never really talked about PD-L1 expression because I'm not even sure if you measure it. Because I think you and I don't think it's so useful in helping for this making this decision for various reasons. And so I wrote you the email, look, did you read the paper? I don't think it's right for that and that reason, right?
Yeah, and over the last several months, I guess talking to people as well at various meetings, excuse me, I went to the Spanish melanoma group meeting, annual meeting, which was in Malaga. I can't remember, that was maybe in May or something like that. And actually I was doing a talk about cellular therapies. Caroline Robert was there, and we were doing our talks. And it's really interesting. The audience wanted to ask about this because they'd seen this opinion piece, and we ended up talking about it. And this is a room full of experienced Spanish oncologists who treat melanoma. And they were thinking, well, we don't really agree with this either. I don't think any of us are dismissing it out of hand. That's important to say. But whether it's a marker that can be used in isolation for making decisions in clinic, I think that's the real point here. So, yes, go on.
It's that should PD-L1 be a biomarker used for regulatory approval? That was sort of the point of that paper, is that, look, we have to be cautious as we approve these drugs. And is there a signal in everybody, or is there a signal in a biomarker driven subset? So the paper was saying, hey, regulatory agencies, this might be your biomarker in melanoma to help discern. And I think behind clinic doors, it's totally different. I don't need, that was part of our point, right? Is that it's not that I want regulatory authorities to use a non-powered correlative exploratory analysis to base their approval on. approve it. This is like ulceration with interferon, right? I do think ulceration was a strong marker for interferon benefit, but I didn't want it to be restricted only to patients with ulceration. That's all exploratory post hoc things. Approve it, and then, allow us to use bits of data individualized for each patient. And PD-L1 might be one that you might use if you have a frail older patient to reassure you that single agent might be sufficient here. Anyway, I guess that was the situation, right? Not that, because some of these drugs are approved on the basis of PD-L1 expression. That was not the primary endpoint of a study. It was not powered to look at that, yet the regulatory agency swooped in and said, we're only going to reimburse for this exploratory subset.
Yeah, no, thanks. I think that's really important. Is this of sufficient quality to base regulatory decisions on? And so, without going into it too much, obviously for Nivo-Rela, the EMA have taken a view actually that it's going to be used. And in fact, there was the same discussion. I'm sure I've told you both of this before, the EMA for Ipi-Nivo back in the day, whenever that was, 2015, 2016. And I made the point there, without going into too much, which is sort of potentially confidential, that we'd love to have a biomarker, but none of us really think in the field that this is sufficient quality. And actually, these decisions should be made in clinic between physicians and patients and their families, and this is one of the things that you may take into account, and I think that's what we want. And then, just to finish the point, the problem then with these regulatory decisions is that reimbursement decisions will often follow the regulatory decision ex-US. And so, without getting into that one, but certainly in Europe, most of Europe, and we talked about this a bit with Nadina as well, our reimbursement follows the labels. So this isn't an academic problem. This is actually a practical issue for patients.
Well, and that is, you vociferously argued at that EMA decision for checkpoint 067. But, again, when they make a decision about approval, non-approval, and then payment, reimbursement that follows suit for non-powered subset analyses, subgroup analyses, what you're actually in essence doing is withholding effective treatment from patients who could get it. And don't withhold the treatment. Allow the provider to have the conversation of, I think this treatment or this treatment, and here's some reasons based on your case. But by putting this restriction on, they have in essence withheld effective treatment for melanoma patients across Europe. That's a problem to me, I think.
Yeah, I think we all agree.
So, Andreas, maybe if you know it off the top of your head, maybe either take us through the points that you articulated. We just signed our name to that article, frankly, that this is all, again, your intrepid work. Maybe take us through the 5 points you made about why PD-L1 may not be an optimal biomarker, or as a teaser, maybe you just tell listeners where to find the commentary.
No, do the teaser, because we're on 37 minutes.
Some of it we're cutting out. It's fine.
Yeah. So people will find it on Monday on JCO, and it's not completely true. It was still teamwork. I just started it. Yes.
You made all these points. Let's be clear. We were like, yeah, that's good. Those are good. Yeah. Right, James? Like, we didn't help him here. He did all of this.
Yeah, so we're coming back to academic collaboration. It's fantastic, We've been working with different places. We're talking, and this is great. Go on, Andreas. You're going to say something.
So the first point was that yes, in Checkmate 067, there is a subgroup analysis with PD-L1 expression higher or less than 1%. But there are also subgroup analyses with a cutoff of 5% and 10%. And if you choose this cutoff, suddenly Ipi-Nivo is better than Nivo. And for a cutoff of higher than 10%, it seems like you have even the biggest benefit of dual checkpoint inhibition. I don't think that's true. It just shows that those cutoffs are not very, very useful, right? I guess that was our first point, but we also added, and everyone who treats melanoma knows that the trial wasn't powered to compare ipi-nivo versus nivo. Our second point was concerning relativity 047, where we saw if you have a look at progression-free survival and look at the subgroup of patients with PD-L1 expression, there seems to be no difference if you look at patients with PD-L1 expression greater than 1%. But that only seems to be true for PFS. If you look at overall survival or response rate, then you don't see the same effect anymore. And I can't find a plausible explanation why that should be true. And then the third point is about the retrospective analysis from I think his colleague is called Elbeck from Denmark. And it's a very well done study. They tried the best you can get out of retrospective data. They did the match propensity score analysis, so they tried to that the patients in both groups are as similar as possible, and they tried to adjust for all confounders you could imagine, like LDH, having brain metastasis, yes or no. But still, after doing that, in the ipi-nivo arm, there were more patients with elevated LDH and more patients with brain metastasis. And this is not a surprise, because in Denmark, oncologists will choose ipi-nivo for patients who have a worse prognosis, where they think the disease has quite a bad dynamic, maybe higher volume of disease. All those things you will not catch with that kind of analysis. And that was also a point we made. And number 4 is maybe one of the problems with subgroup analysis is that we do randomization to be sure that all confounders are well balanced between the two groups. But if you then go into subgroup groups, you can't be sure anymore that those confounders are still well balanced. And we said, look, for example, we know that ipilimumab is very strong when it comes to patients with BRAF mutation. And we don't know how many patients with BRAF mutation have PD-L1 greater 1 or below 1. So it becomes very complicated to interpret, do a proper interpretation. And another point is measuring PD-L1 expression is it's not that simple. You can have a lot of problems. First, where do you measure PD-L1 expression? Metastasis, primary, and there is some work that depending on where you measure it, it might be prognostic or not. What do you do if a patient has a PD-L1 expression of greater 1 on a metastasis, but below 1 on a primary? Is the patient positive or not? Many problems with that. And we also highlighted that. And the last point is subgroups per se are problematic for many reasons. Usually they are not powered. Usually you have multiple testing. Usually they are not pre-specified. You will always find a significant subgroup. How do you deal with that? So I guess that were our main points why we are like, we don't think you can use PD-L1 alone to guide your decision. It's not that easy.
I love the way he talks about strength there as well, Andreas.
Yes.
If he is strong in BRAF mutant melanoma, I love that. Sorry,
Yes.
go on, Sapna. Excellent. Okay, well, Andreas, that was great. We're going to wrap up now. Sapna, do you want to wrap up?
Oh, no, I think you should wrap up.
No, I introduced Andreas. You should wrap up.
Well, Andreas, it was so lovely to have this discussion with you. I think this shows us the value of having teams and having diversity of thought and people. When we just sort of are stuck in our way, it's not that we're stuck in our ways. It's that you need people to just inquire, whether that's a nurse, a fellow, a colleague, somebody else. It's actually why I feel like we have a lot of fun doing this podcast. It's just maybe we think the same, but maybe we don't. And it's nice to have people just sort of bring questions. So, well done on you, and continue reading and, finding all the questions we've talked about, but don't have the energy to go after. But thank you for joining us, and hope you stay well in Basel. Hope to see you again soon.
Yeah. Thank you for having me. It's very nice. Thanks.
Thanks, Andreas.